Thank you. So really enjoyed this symposium so far and enjoyed hearing a lot of theoretical approaches. And so my talk is really going to focus on how we've applied some of these concepts that have been discussed here on the exposome to answer a clinical question in my field of medicine, which is liver disease. And so I'm going to spend kind of the middle to the end of the talk talking about an exposome study that we're doing with support through a Victor mechanism with two interacting P30 centers at the University of Louisville and Emory Hercules Center with new to EHS investigator Naga Chalasani from Indiana University. And so I think along the way that I can hope to demonstrate some value of these funding mechanisms. And so I wanted to start off by just talking a little bit about liver disease. And so why should one care about it? I know we've got at least one other gastroenterologist here that I assume cares about liver disease, but I know most of you are not. And so why? So in Kentucky, we care a lot about it. Because we have more bourbon barrels than people, they say, in the state of Kentucky. I care about it because there's a real increase in liver disease prevalence that keeps me clinically busy at times. And so the cirrhosis death rate has really increased dramatically even before the pandemic. And the alcohol death rate, even before the pandemic, was increasing, particularly in women. And so this really accelerated during the pandemic, along with the increase in alcohol sales. And so nowhere was it increasing more than in young people, and in fact, primarily young women. And in fact, with the latest mortality statistics, liver disease deaths in people under the age of 44 were just barely below COVID deaths. So this is a big problem that we're seeing. And so these are some of the clinical manifestations that keep me up as a practicing physician: the ascites, the bleeding varices, multi-organ failure, liver transplantation. But what's the environmental component of all of this? Well, this is on Y liver EPA. These are IRIS data looking at different chemicals tested and different organ systems or organs that are impacted. And in this study, almost 25% of chemicals tested had a non-cancerous liver endpoint, and kidney was next, and it was 30% lower than liver. So liver is a very common organ for industrial chemicals. So we've heard a lot about plastics throughout this symposium, and a lot of the plastic story really originated in Louisville in some ways, and that was with the recognition of hepatic hemangiosarcoma liver cancer that occurred in chemical plant workers that were exposed to vinyl chloride. And so these exposures were incredibly high, thousands of ppms. The first report was in 1972 in JAMA, and the gentleman on the top right, Carlo Tamburo, was recruited to Louisville to do occupational surveillance. And so that led to reduction in exposures in the plant, which decreased liver cancer. Now, Dr. Tamburo developed a large biorepository of biological samples and liver biopsies in the plant workers he was following. And then I used that biorepository to describe the new liver disease, toxicant-associated steatohepatitis, which we'll talk more about in 2010. So the liver cancer cases still present. In fact, I took care of one in 2011, and today we've had very generous support from NIEHS and multiple centers with liver components to them, but this dates all the way back into the 1940s when production began. We've heard a lot about environmental justice and health disparities. You can see the plant at the Rubbertown complex in your lower left. You can see the neighborhood next to it, and there's a Lees Lane landfill down the road. And so you can imagine the issues with justice and disparities associated there. and that landfill is our Superfund site for our Superfund Research Center. Histology and a CAT scan with a large tumor from the worker that I took care of. And so when I was a fellow, I found an old box of slides from liver biopsies from plant workers in the 1970s that had a high prevalence of fatty liver with inflammation or steatohepatitis, and scarring or fibrosis. And these workers were lean because they were healthy workers, presumably, and they had to fit into these reactor vessels to clean them. And so they reported not drinking, and they didn't have risk factors to have any liver disease. And these are what the biopsies look like. This white Swiss cheese looking holes are fat droplets, and you can see all the inflammatory cells. That's an H&E stain, and this is a trichrome stain where you can see the ring of collagen. So this worker actually had liver cirrhosis, and they had a fatty liver. And this fatty liver was associated with metabolic disruption, diabetes, abnormal cytokines, but curiously normal ALT. And so I'll talk a little bit about that later. And so I actually discovered this when I was a fellow, just snooping around the biorepository, and it's been very rewarding to see over the last 10 years, this findings that I reported in the microscope, wondering if they were real or not, just to going from discovery to now a practice guideline a few years ago. But not to get a big head, I don't know where Bob is, he'll appreciate this. So Mount Sinai knew about this 30 years ago, and they just didn't publish it. So I found at our biorepository fairly recently this letter from Mount Sinai from Hans Popper, who's regarded as probably the greatest liver pathologist of all time. And he looked at some of these slides, and Hans said, this biopsy specimen shows so-called fatty liver hepatitis, yada, 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 yada. I cannot exclude alcoholic liver disease. If this is firmly excluded, I could consider toxic injury and hope to receive follow-up information. And so I don't guess he got the follow-up information. So I just rediscovered something that was known here at Mount Sinai in 1979 when I was 5 years old. So I was not as smart as I thought. And so we've spent a lot of time doing reverse translational research, doing some metabolomics, which we'll talk about more in human studies, and animal models to describe mechanism. I'm not going to talk a lot about this, but one thing that's important in this field is nutrition interactions. We've heard about lifestyle factors a lot. This is a study done by Juliana Bayer, who's at Pittsburgh now, looking at low-dose vinyl chloride exposure, sub-OSHA levels, with or without a high-fat diet versus a low-fat diet. Red is lipids, so high-fat diet causes fat in the liver. High-fat plus vinyl causes more. The vinyl itself with the low-fat diet didn't cause anything, so there's a diet interaction in the toxicity of this, and it's believed to be related in part to generation of reactive intermediates from the parent compound, which form adducts and organelle stress and dysfunction, such as mitochondrial dysfunction. And so what is this toxic and associated fatty liver disease? And Tash, what is steatohepatitis? So this is the most common liver disease, non-alcoholic fatty liver disease, affects about 1/4 of the world's population, and there's no FDA-approved medicine for it. And so whatever the exposure is, there's a fatty liver disease. So alcohol causes fatty liver disease. We call it alcoholic hepatitis. Diet-induced obesity can cause it, and so we call that non-alcoholic fatty liver disease. And then environmental pollution or occupational exposures can too, and we call that toxic and associated steatohepatitis. But these diseases are really poorly named because, what about somebody who's a little overweight that has some exposures and, drinks a couple beers at night? They have all of these factors. The other thing that's important to know about the disease is it's progressive from fat accumulation into the liver to hepatitis or inflammatory infiltrate to cirrhosis or liver cancer. And so some, but not all, patients progress, and can exposures be part of the reason for that? And so we wanted to then ask the question, if high-level vinyl exposures in a plant can cause fatty liver, what about low-level environmental exposures? And so we're asking that question a little bit before 2010, and I didn't know until just about an hour ago what I wanted. I wanted an environmental liver disease exposome atlas, and but I didn't know it at the time. And so that's the question we wanted to ask. We wanted to use something like an exposome, and there's been a lot of epi studies since, and you can see, regardless of what the exposure that you're interested in, there's a good chance it's been associated with fatty liver disease in an epi study. And interestingly enough, Andrea Branch here at Mount Sinai has done some really neat work on the World Trade Center exposure, or first responder cohort, and found a high prevalence of liver disease there by CAT scan. The work's been interesting. It's work on Roundup, our Superfunds doing VOCs and residential VOC exposures, and liver effects as well as cardiovascular. We've worked with the Gulf cohort with Deepwater Horizon cleanup, and the C8 cohort from the movie Dark Waters. It's been really rewarding, but my patients don't come to me saying, I was from one of these cohorts, and do I have liver disease? They come to me because they have liver disease, and they want to know why. Are they going to die? How sick are they? And so our initial attempt to try to answer the question about general population exposures and an exposome, again, we didn't know what the term was at the time. We used NHANES in 2010. And so this project was actually paid for through a P30 Career Development Award to me. It's really got me jump-started in environmental health. And so I'm really grateful for that. And we looked at exposures that were measured in NHANES and a surrogate biomarker of liver disease called unexplained ALT elevation. And to make a long story short, I was really glad that Doug talked about PCBs and dioxins, because they were still relevant. That's what came out: PCBs, dioxins, and organic chlorine insecticides, and a few metals. And these are odds ratios for this surrogate biomarker called unexplained ALT elevation, so the toxicologist in the room can see a dose response there. And so I, at the time, had never even heard of a PCB. I'm a clinician. I wasn't an environmental health scientist. And so what I did was I pulled up the MSDS for PCB, because I have a chemical engineering background, and read about that. And so there's an excerpt from Monsanto at the bottom saying that mouse models get liver disease, and they get it before cancer. So usually you think of Monsanto denying all health effects. Well, here's a health effect they reported. So I figured it must be real, but nobody had really been looking at it. And so just like in vinyl, we've been developing animal models primarily under an R35 award. And a lot of this work was done by Benrito Wulong, who just received a K award from NIEHS to look at sex differences. But the story is very similar to the PCBs. You can see the red fat droplets again, and they really depended on the diet as well as the visceral adiposity. So these were, at least this PCB 153 was an obesogen, but it was a diet-dependent obesogen. It made diet-induced obesity worse, but didn't cause obesity on a healthy diet. And so I think that's a concept that may be important for environmental chemicals, that maybe even if exposures are going down with a worse diet, their potential toxicity, is revealed. And so we've found a variety of mechanisms. I'm not going to discuss those further. And so moving towards the exposome, this is a fantastic study, probably the best, I think, in all of environmental liver disease. I wrote the editorial for this that was published in Hepatology about a year ago. This is a DOAD study, a birth cohort, looking at maternal PCB levels and fatty liver in the kids after about a decade or so of life. And so they were looking at PFASs, and here you can see, again, for the toxicologist, a clear dose response of circulating PFASs in the moms and the risk of fatty liver disease in the offspring. And then moreover, they did metabolomics in the kids and then looked at the relationship between the kids' metabolites and the mom's PFAS exposures, and they found differences. And suggesting a mechanism or a reprogramming of metabolism due to the maternal exposures that persisted in life and increased the risk for the development of fatty liver disease. So that work was done at the USC P30 Center and others. And I think it's a really scary story, is the liver disease epidemic that I alluded to due to the exposures that our parents and grandparents had. Very scary to me. But there's not a lot more environmental or occupational liver diseases than just fatty liver disease. And I'm going to show a couple slides on one of Doug's recent publications on cholestatic liver diseases. And so they published on PBC, primary biliary cholangitis, and PSC, primary sclerosing cholangitis, with an exposomics approach. And so here's a ERCP test looking at the bile ducts, and that's where a gastroenterologist cannulates the bile ducts and injects dye. And so there's an autoimmune disease where the body attacks the bile ducts, and that's called primary sclerosing cholangitis. If it's the big bile ducts, you can see by X-ray, but there can be a microscopic disease called PBC, where it's the smaller bile ducts, microscopic in the liver. And so they performed HRE, HRM, and plasma from subjects with or without these diseases. And interestingly enough, there were some things that were consistently increased in terms of exposures. There was a phenol, nonyl phenol, that was up both in PSC with or without IBD, as many of these patients have, and also the PBC patients. And then this metabolite, which is believed to be helpful, procatachoic acid, was increased in both. There were some exposures that were decreased in both of these diseases, an herbicide and a carbamate insecticide. And then there was a variable response to PFASs, with PFOS being decreased in PSC and PFHSX being increased in PBC. And so here's a network analysis where you can see things like the procatachoic acid, the nonylphenol, and PSC at the top, PBC at the bottom, interacting with various metabolic pathways, kind of like the DOAD study in the kids, showing some alteration in metabolism associated with the exposures. And so this takes us to the Victor project that we're doing. And so we're doing a exposomic study in NAFLD patients. And so again, patients come to clinic, they've been diagnosed with disease, and they want to know what's caused it and what their prognosis is. And so I took a different approach here. When I asked these patients, unless they're at the VA, then VA patients could tell us if they had burn pits, Agent Orange, firefighting foam extinguishers, but the run-of-the-mill clinic patients, you ask them what their exposures are, they have no idea what you're talking about. And so we did not do a case control study. Everybody had the disease, and we're looking to see, because there's a spectrum of disease, can the disease severity be affected by the exposure. And so to do this, we used an imaging biomarker called FibroScan, which is a probe that goes on the side and measures liver stiffness and gives a readout of liver fibrosis and liver steatosis. And we used the express liquid extraction approach that Doug had described. And so, again, we were looking at NAFLD patients that came from Indiana University. We looked at these vibration-controlled transient elastographic disease biomarkers, and then we did HRE and HRM as described, and then did EWAS and MWAS studies, exposome and metabolome-wide association studies with a network analysis, as Doug did in the PBC and PSC study. So the approach was very similar, it was just a different patient population. And so here's the demographics. And so this was largely a female cohort. They were middle age. The mean BMI was around 34 or 35, so obesity, high proportion of them were diabetic. The disease was relatively mild in severity in terms of the steatosis and fibrosis at the median values, but there was a range, as you'll see. And so at first, I'd like to show some of the results from the MWAS, metabolome-wide association study, and we did this a couple of ways, either continuous or categorical values. And from the Manhattan plot, you can see that we found a lot of metabolites at various levels of statistical significance, P of less than 0.05 or FDR of less than 0.2, that were associated with CAP, which means they were associated with the severity of the hepatic steatosis. And then you can see here's the range of the CAP. The max is 400, so we did have some that maxed out that value. Now, what pathways were important? So here's pathway enrichment analysis. So not surprisingly, a fatty acid pathway, linoleate, was at the top of the list. Now, we did this for fibrosis, which is or liver stiffness measurement was our readout for fibrosis. And this is really important because this is what kills people with liver disease, is their degree of fibrosis. It's not the degree of steatosis. And so similar, we saw perhaps fewer metabolites associated with it, but again, we saw linoleate as an important pathway. So it was number one on categorical, not number one on continuous, but it was still a significantly enriched pathway. And now on to the exposome part. You know, again, my goal is to have an exposome disease map. And so here's the exposome part. And so we were able to show some chemicals that are associated with the liver steatosis or CAP. And I'm not going to go into all of those, but I wanted to highlight a few of them. So in Doug's paper on cholestatic disease, he found nonophenol, and here's octophenol. So we see some consistency with environmental phenols, which none of us had considered. And then I'd never considered PAHs, and then we have PAH fluorine that popped up. This is the integrated network analysis, and I think these data are really cool. So down here, so we've got, I think, 5 different colors of communities of metabolites, which are in circles, and then triangles are the exposures. And so you can see these communities of interacting exposures and metabolites. Now the clinical biomarkers, the LSM, fibrosis, CAP, steatosis are here. And so this blue family and this gold family are interacting with these. And so there were 4 exposures, fluorine again, PCB 132, diphenylnitrosamine, that were associated positively with both of the NAFLD severity biomarkers. And up here at the top, BDE2. So look at all the metabolites associated with BDE2, but it wasn't associated with the fibrosis or the steatosis, but clearly associated with metabolic disruption. And so what's the importance of the BDEs in the disease process? And so next we did another MWAS study, but instead of MWAS versus disease severity, we did MWAS versus the fluorine exposures to see what pathways were associated with fluorine exposure. And again, linoleate popped up. So we know this was a key pathway for fibrosis and steatosis. It also seems to be associated with linoleate, raising the question, is linoleate's association with liver disease severity mediated by disturbances to the linoleic acid metabolism pathways? And so in conclusion for that study, we saw several exposures that we hadn't really considered before that were associated with the severity of non-alcoholic fatty liver disease, including a PAH, the PCB again. So when I did this study, I've been doing PCBs for over a decade now, so I was wanting to do something different, but yet they keep popping up. But I guess that was in some ways an internal validation of what we already knew. Nitrosamine, which I never considered, and then this phenol, which seems to be consistent across at least 3 different liver diseases now. It's slightly different phenol, but no one's been looking at environmental phenols in liver. So there are some limitations to this study. So is it generalizable? There are a lot of females, there were a lot of diabetics, they were from a single center, and a cross-sectional design. The models weren't adjusted. The sample size was about 140, so it wasn't huge. And so we're trying to address these now through some validation cohorts. And so Dean's just run about 1,000 exposomes and metabolomes from about 600 more NASH patients. And we're excited about this one here at the bottom. And I think I want to spend a minute to talk about this because I think this is a good direction for exposome research. And so we're accessing samples from a clinical trial. So I do a lot of clinical trial work too for companies. So almost every major clinical trial has a biorepository now. And these patients have very rigorous inclusion and exclusion criteria to limit confounding. And they have very careful, rigorous disease phenotyping. And then they have longitudinal samples, which I guess now means we can do environmental biodynamic monitoring. I called it a longitudinal study before today. And so that's what we're going to do. And so we're going to look at the natural history in the placebo-treated patients, but we can also look at precision medicine in response to medication therapy in the drug-treated patients. So is there an environmental FXR antagonist that makes the pharmacologic FXR agonist not work? So we'll be able to find out. So I think this is a good approach that many of you may be able to adopt to whatever disease you study. A cautionary tale, a couple of slides. So another, I think, take home for exposome that I believe is important is don't become so enthralled with the technology that you forget to have a good study design. And one part of that is choosing your clinical biomarker very carefully. So if you're doing your association studies, but you're associating with a biomarker that's flawed, your study may be doomed from the start. And so as an example of that from my field is ALT. And so this is a paper that's in preparation by one of my fellows looking at this FibroScan to diagnose fatty liver in 4,000 patients. And how many of those had an ALT abnormality? And so the sensitivity of ALT to detect fatty liver ranged from 31 to 58%. And so it was actually worse than random chance, depending on the cutoff. You would have been better off with your NFL coin toss on figuring out, whether your patient had fatty liver. And so if you're using ALT, and I'm not saying don't use it, but if you're using it, don't be surprised if you don't get the results that you're looking for. What can you do about it? This is a paper that was published in EHP a few months ago. And so the problem with environmental epi studies is you can't do biopsies, can't do liver biopsies. So patients aren't going to sign up, IRBs aren't going to approve, and you may want a biopsy of whatever tissue you study, lung, heart, who knows. And you can't get it in, you can get it in a clinical trial, but you can't get it in an environmental epidemiology residential cohort study. But one thing you can do now is do liquid tissue biopsies. And so that we do that every day in industry-sponsored clinical trials for development of companion diagnostics. And so we applied that approach to environmental epidemiology. using high throughput microRNA biomarkers, which in this case we found were associated, whoops, always hit the wrong green button, associated with PCB exposures. And then you can put these microRNAs into just an IPA and it'll generate liquid tissue biopsy. So we saw kidney injury, liver injury, HCC pathways, liver cirrhosis, liver inflammation, and then cardiac fibrosis in this Anniston Community Health Survey, which is a PCB highly exposed cohort. It's from Anniston, Alabama, where Monsanto operated a plant. And so this project was interagency collaboration with Brian Chorley at EPA and Marion Pavick at ATSDR. And then last slide here, and this is, I always love to close on dioxins. So this is a Linda Birnbaum study that we're writing up now, where we're using a big liver biomarker panel. And so this is the phase 2 of the Anniston Community Health Survey, which was a recontact study, which was done because the dioxin-like PCBs, the non-orthos, were not measured in the initial cohort. And so what was done in this study is kind of a targeted exposome. So they measured basically every dioxin that has a World Health Organization toxic equivalency factor. So I know Robin alluded to AHR and dioxin, so that's exactly what we did. We, looking at the associations of AHR activation by environmental pollutants using the total dioxin toxic equivalency and associated it with a big panel of liver biomarkers. And so these were microRNAs again, but here we had the whole liver function test clinical panel, AST, ALT, bilirubin, et cetera, et cetera. And so on complete linkage analysis, these liver biomarkers, they were separated into 4 groups. And so all of the regular liver function tests were in the second group. And so what are these groups? So Brian Chorley did IPA on these, and you can see here that the different groups basically are measuring different things. And so we looked at, did the association studies, and that we found that the miR29 was associated with toxic equivalency, total protein, albumin, miR185, but we didn't find anything for AST and ALT. And so the point is, if we just looked at those biomarkers, we would have missed these associations. And the cool thing is albumin. So people talk about liver function. AST and ALT are not liver function, they're liver cell death. Albumin is liver function. And so Tim Zacharewski's groups published that TCDD decreases albumin expression in the liver. And so we were able to show that toxic equivalency was associated with low albumin in these patients. And it wasn't just total dioxin toxic equivalency. If you did the subgroupings, the PCB toxic equivalency, the PCDD toxic equivalency, or PCDF, and the PCDD were all associated. And if you looked at the individual congeners, over half of them, including TCDD and the most potent PCDF, were all associated with low albumin levels. And so, here we're seeing a different biomarker, albumin, which we hadn't been investigating before, that's inversely associated with exposures. And so I think this just illustrates the importance of looking at a variety of clinical endpoints in your association studies, which could include exposome. And so, in conclusion, chemical pollutants appear to impact liver disease development, progression, severity. These integrated metabolomics and exposomics approaches that we've been hearing about appear promising in these disease states. Metabolism disruption seems to occur based on the metabolomics studies, and the nutritional interactions with the high-fat diet have been shown to be very important, at least in the animal studies. And so don't forget the importance of carefully selecting your disease biomarkers. For the epidemiologist, talk to your clinician buddies, because everybody in hepatology knows ALT and AST are not good biomarkers. We've got people dying of alcoholic liver disease with normal liver enzymes, but we don't do a good job about letting people know that. So involve your clinicians, and don't forget about these clinical trial biorepositories, which I think are a really cost-effective source. So we've got 2 years of longitudinal samples, multiple time points, and we got them all free of charge from an NIDDK-funded study that was sitting in the freezer. So don't forget about that resource. And these studies, again, are supported through a Victor mechanism with interacting P30 centers, and I think that's been a very fruitful type of interaction, and so we really appreciate NIEHS support on that. So welcome to take questions. Thank you.